Good morning and welcome everyone. I want to thank each of you for joining the Better Medicare Alliance's panel on addressing health disparities in Medicare. I am delighted to moderate today's important session and discuss how Medicare Advantage plans have been working to address health disparities in the communities they serve. There is no denying the fact that COVID-19 has changed everyday life for all of us in a multitude of ways, and that our country is experiencing a moment of racial and social reckoning. As the death toll passes 210,000, the COVID-19 pandemic has laid bare inequities within the US healthcare system and our society at large. Black, Latinx, Indigenous, and Pacific Islander American communities bear an unequal burden. Blacks are 3 times as likely as white Americans to contract the disease, 5 times as likely to end up in the hospital, and twice as likely to die from it, according to several studies. This, as we are quickly moving to becoming a more diverse country, and the ranks of America's older adults are expanding rapidly. 10,000 people, in fact, turn 65 years old every day in the United States. This has profound implications for Medicare, especially as healthcare leaders struggle to address the social determinants of health for our most vulnerable and marginalized communities. Not to mention the increased pressure to improve the quality and value of healthcare in an increasingly diverse and aging society. Today, we aim to identify the barriers that are preventing the advancement of health equity, along with the best practices that leaders in the field have put into place to move the health equity needle forward. So I'm excited to dig into some of these topics and learn from each of our panelists. So without further delay, let's begin our discussion. We have a lot of ground to cover, and we are so fortunate to have 4 of the brightest, most innovative, forward-thinking minds in healthcare to help us better understand and address the challenges and opportunities moving forward. It is now my distinct honor and privilege to introduce our esteemed panelists, and then we're going to move into our question and answer segment. Joining us today is Caraline Coats. She's the Vice President of Humana's Bold Goal and Population Health Strategy, where she leads Humana's vision to help improve the health of the communities it serves by making it easier for people to achieve their best health. She's a nationally recognized population health expert. We are so honored to have you, Caraline. Next is Michael Currie, a distinguished alumnus of Morehouse College in Atlanta, Georgia, who is the Chief Health Equity Officer for UnitedHealth Group. He leads the development and execution of enterprise efforts, initiatives, and interventions to identify health disparities, as well as the enhancement or implementation of programs, services, and strategies to address identified health disparities. Thank you so much, Michael, for joining us. Our third panelist is Dr. Garth, a cardiologist by training and Vice President of Community Health for CVS Health. He is a leading authority on social determinants of health and works closely with CVS's Health's many businesses to develop a more equitable strategy to address community health needs. And rounding out our panel is Dr. Gary Puckrein, President and CEO of the National Minority Quality Forum, who's been a trailblazer in the movement to advance health equity. Under his leadership, the NMQF launched the National Health Index, which measures and forecasts health status, monitors health outcomes, and undertakes risk assessments. Thank you for joining us this morning. Good morning to each of you, and welcome. So I want to begin our discussion by talking about health equity generally, right? We're aware that there are various layers or dimensions to health equity. It is a multidimensional issue, but where and how do we start to address health inequities in our communities? I open that up to everyone.
I'll take a stab at that, Daniel.
Thanks, Caraline.
I think I came off mute first, so no. Good morning, and thank you for the introduction. It's a heavy question, and I don't think there's one answer. Leading Humana's population health strategy, that's really powered by what we call our bold goal, is really what's fundamental in that is the community. And so we have many markets ask, how can I be a bold goal market, right? And it's not something just to optically sound good. It's about connecting with the community and understanding at a very micro level, what are the real barriers to our members achieving their best health? And so we talk about it that way. We use all these words and social determinants and ease of health and outcomes and all of that. But at the root of it, it's really about, is it where someone lives? Is it the air they breathe? Is it an emergency, hurricane area and it's causing anxiety? Is it lack of access to healthcare or school, right? And so these are, it takes years to really understand what those barriers are. And so from a payer perspective, from Humana's perspective, we have a lot of data. And so I think we're really starting to get some momentum at turning that data into actionable information. So we've been doing a ton of screenings, for example, on our members around their health-related social needs. And I deliberately say health-related social needs because that's really what we've been focusing on. We've a lot of, I'll probably talk about it more later, a lot of programs around delivering food and offering social interventions and visits and rides. In my opinion, those are really the social needs that are symptoms of deeper issues. And so when you ask, what are we doing to get at those health inequities? I think we're just now taking the last 5 years of this bold goal work and understanding the health-related social need data and looking at the higher prevalence among certain communities and then digging into that next layer to really understand those determinants and keeping fundamentally at that community level and not trying to solve something at a corporate perspective, but really understanding, listening to the community, convening the community and creating some collective impact to really understand what are the inequities in where I live in South Florida are likely different than where I'm from, which is Detroit, right? And so really, and that will then drive what solutions we need to invest in and how we measure that, which I think we'll get into some of that. But listening to the research, the data, and listening to our community are just a few areas of where we're starting.
I love it. I love that you started out by talking about the root causes, right? And the interventions at that community level. And you talked about collective impact. All I think are extremely important, right? To move beyond merely nibbling around the edges of the problem of health inequities in our community. How about our other panelists? Any other thoughts?
Yeah, I jumped off mute second, Caraline. So I'll go right after you. And just to dovetail on a couple of key points, I think we all agree that all health is local, and much of what's been driven around individual health and communities is defined by the status of a number of things in communities. Here's one aspect that I think has been the topic of conversation this year, and I think has been a heightened topic of conversation for many decades for those of us who've been working in this field for a long time, and that's the impact of things like racism and how that has structured communities in a disadvantaged way. We've been particularly committed to a number of factors, not just understanding how we deal with issues around current social terms of health, but how investments around things like housing and transportation, and housing in itself is many times linked to inextricably a long characteristic series of events that has led to certain communities living disproportionately in certain housing environments versus not, as well as contributing to the lack of affordable housing for many others. So certain area we've been committed to, but I think that the point to understand here is that understanding the root cause of health inequities, as you just articulated, cannot fully be done without articulating the component that institutional racism plays within that. And I think much like my colleagues here, I think much of our investments and our initiatives are targeting those kinds of activities at the community level that are meant to really combat not just what's currently happening, but a lot in terms of the history of how we got there.
I'll layer on to that, Daniel.
Yes.
And I'll layer onto it in two particular areas. One is the difference, because I think it's pretty important to level set everyone's understanding this difference between health equity and health equality, because there's a very intentional focus on health equity. Equality is giving everyone the same thing. And in certain circumstances, that's fine. But by pure definition, again, equality is lining up the same thing for everyone, assuming that whatever that same thing is going to have the same desired effect and outcome for everyone. And we know that's not the case. Equity, on the other hand, really gets at the heart of providing care, support, and services that are unique to an individual's very specific needs. We've seen images of boxes and bicycles that are provided to individuals based on their needs, whether they're disabled, tall, small, large, whatever age they are. So first, getting grounded on this notion of equity and health equity, that is foundational to every single one of our efforts, whether it's CVS or Humana. If the Blues were here, it really wouldn't matter. Cigna. The equity focus is foundational to us. And the other thing that's foundational to us is health insurance or managed care organizations, is the fact that the overwhelming majority of care is not provided by us. We do our best work at care support. So it's incumbent upon us, for those that outreach and engage with our respective members, to be culturally sensitive and appropriate and aware, and be able to adapt and remove implicit and unconscious bias from their interactions and outreach with members. And for us also to leverage whatever those best-in-class opportunities are to support the providers and clinicians that we have in our respective networks. The reality is they're in all of our networks. It's going to be the same doc that accepts insurance coverage from each of our networks. So there really is no competitive advantage for us to not work together and continue to work together and offer providers and clinicians in our provider directories the support that they need so that they can deliver care in the most culturally effective and culturally appropriate way. And we do the same, offering care support.
I'm going to, I have to get this in there. I know it's not my turn, but I love what you just said. And just speaking of networks and providers and directories, in the spirit of this conversation and all of us working together, I would just challenge us all to think about our provider networks and directories not just being doctors and hospitals in our future, right? So a lot of what we're talking about addressing requires sustainability in the community-based organizations. And so that's just my dream, that our directories one day will have the other providers there that we all need to address the 60, 70, 80% of our health. So
that's right. And I'm curious, you know, Gary, you've heard from our three panelists who work for payers. I'd be curious to hear your perspective on, you know, where and how we start to address inequities.
Oh, I can't tell you how excited I am by this conversation. So I'm an old dog. I've been doing this a little bit, right? And what I know is that the American healthcare system, when it was first imagined back in the 1940s and 50s and 60s, inequalities were acceptable, right? That it was understood that we were going to have inequalities in the system, and it was okay. That the language of race and segregation were all okay. You know, we've now come to a place where we're saying that that's not okay, but what's even more exciting to me is that we're making the business case that it's not okay. People talk about Black Lives Matter. That's what I just heard people say here, that we are going to invest in taking care of Black lives. That is such an unusual statement in American history. I hope nobody does not appreciate the value of what you just heard from these companies. That is extraordinary, right? And so it makes me incredibly optimistic about the future and what we can do together to really change the landscape and now reimagine a healthcare system that is providing equitable care to all patients. So this is really an extraordinary language. I grew up where you couldn't go to water fountains in parts of the country. You had to ride in the back of the bus. You couldn't go to certain hospitals. Certain doctors didn't want to treat you. We've had examples where we talk about this epidemic. smallpox epidemic in the 1880s where they didn't want to provide care to African Americans. They were quite happy to see them die off. So anyway, my point is, we cannot lose sight of what we just heard of from major companies who are saying that they're prepared to make an investment in communities that have long been underserved. I think that's a really important thing to hear.
Yeah, I totally agree with you, Gary. I think that's huge. We heard, the root cause discussion from Caraline. We heard about racism from Garth and health equity from Michael. And I was, in a classroom just yesterday, we were talking about how during the negotiations around the Affordable Care Act that, we couldn't even use the term health equity. We hadn't gotten there yet. We had to stick with health disparities so that it wouldn't drive folks away from, the agenda that we were pushing, which was to ensure that we have a more healthy and inclusive health system. So let me move to our next question. And it's to, really delve into the work that you all have been doing in Medicare Advantage to address health inequities and the social determinants of health. Could you share some? I know, Caraline, you talked about the work around Bold Goal and your population health initiative. Perhaps we could start with you and then go from there.
Of course, yeah. So the Bold Goal, the goal is to improve the health of the communities we serve by making health easier and improving outcomes. And it started with just really getting deep in a handful of communities. We've now more than doubled that. And we've been pretty deliberate on where we do that. So again, it's not just something that sounds good, but it's real. And it's a true investment, and it's resources in the community who are connecting with other community leaders, where we convene health advisory boards, where we have nothing that says Humana intentionally in that room, right? This is about the community, and this is to hear from all constituents, municipalities, school districts, providers, food banks, all of that, really aligning around what are the top couple issues that we're going to convene and really try to drive impact in that community. And so I have this kind of picture of this pyramid, Maslow's hierarchy of needs in my head whenever I think of what we do, because it really is rooted in the community. That's layer number one. And you don't just go past that. It's a continuous nurturing of that. But once you kind of get that momentum, then we really focus on integrating social determinants of health into the way we think and work, into our DNA. So empowering every person who interacts with our members, whether it's a care manager in a home or a pharmacist on the phone, with screening for social determinants of health, asking the Healthy Days questions, starting to, even if they're gateway questions, start to have conversation that shows we care about you beyond your diagnosis. We know you're going through a moment, but we want to make sure we know what home you're going back to if you get discharged. Do you have access to food? All these things. And so there's that integration is still going on, and it always will. And then the next layer is really influencing, right? And so hopefully with all of that data that shows there is benefit qualitatively and qualitatively to investing in the community and integrating, we can influence policy. And we can look at things like social risk indices, and to the point on health equity versus health equality, right? You have a diabetic population that's affluent, that isn't food insecure. You have a diabetic population that's not, that lives, where there's not anywhere other than a food mart with unhealthy food within a 5-10 mile radius. I think we should pay those providers respectively differently to care for those members. There should be different. We're not going to get there until we're really diligent with that integration and data and influencing policy. Right? We need to think political determinants of health. And then ultimately at the pinnacle of that, you can really start to improve health in various populations. And so that's kind of a very high level summary of the work we're doing around the Bold Goal that's rooted in social determinants of health, and understanding the social needs and using the data to then figure out what interventions do we need to invest in to generate proof points to ultimately be an engine for that payment reform and benefit reform. So I have an example on just looking at populations differently. I have a mother with Alzheimer's, and she doesn't need the traditional MA plan that we offer. She may never have an elective outpatient surgery again, right? She needs a health plan that instead of underwriting and paying for those services, pays for healthy food in her refrigerator and X number of state rides So whether it's about a chronic condition or a race or population where someone lives by zip code, get on my soapbox there, but I think we're moving towards looking at structuring healthcare differently, but it's moving slowly, and it starts with capturing a lot of this data and understanding what those needs are. And sadly, I do think COVID has been an accelerator, sadly that we had the pandemic, but positively that it's an accelerator to this movement a little bit. So.
Well, thank you, Caraline. It sounds like you all are taking a 360 approach and moving further upstream in your work. Garth, Michael, any of you want to share what you're doing?
I again followed Caraline by coming off of mute next to kind of dovetail and touch on a couple of the issues that are important, I think, to us. And I think this concept around identifying the challenges in the community, particularly as it pertains to our Medicare population, is, I think, integrally important. And those include looking at things like social isolation and understanding that loneliness, and there's a clinical component to loneliness, and I think there's a social aspect, and very much so in terms of understanding the interrelation between the two is particularly important. So I think from our standpoint, we looked at developing a social isolation index and using that to link a lot of our members who've been disproportionately impacted by social isolation to resources, community resources, the things that connect them, including our program we have called Resources for Living. One of the things that we and I think others do, but I think is particularly important, is this concept around understanding what's happening in the home. Because the home is the pinnacle for so much that happens in a senior's life. And the in-home assessments, we offer an annual in-home assessment that really kind of looks at kind of what's happening in the home and also the clinical dynamic that's happening in the home along with the member. And I think to Caroline's point and dovetailing on that, all of these things are about understanding what's happening in that individual's life and in an individual's environment. Now, understanding the component of health equity that goes along with that is then understanding how different, someone's home in one particular zip code may be in another zip code that may be 5 minutes away, and why those zip code life expectancies may be 20, 30 years apart, a lot of the maps that many of us are familiar with. And it's about understanding the kinds of dynamics, the kinds of things that are happening both in the community and in the home. The last point I will make, and I think, Michael, you alluded to this before, is this concept of, disparities, equities, and health equity, and why these definitions are important, though not interchangeable. What we have to be able to do is to understand how we have each individual live their best life, and what are the kinds of things that you can do to fund that, support that from birth to the end of life. And I think particularly when you're in those latter parts of those last couple of decades in life, or when you're the most sensitive to the kinds of things that make inequities disproportionately challenging. And I think that's where being able to connect people to resources is particularly important.
Yeah, to Garth's point, really starting to focus on those things that we are doing and will continue to improve upon. Each of us is doing work to understand those social factors and environmental factors, or what we commonly refer to as social determinants of health, that really impact someone's ability to seek care and then be compliant with whatever their care is, whether it's food or housing or income or education related, whatever it may be, or some other social service, domestic violence, the list goes on and on. We have a community health model, and I'm sure at Humana and at CVS, they may call it something different, but the reality is it's going to be some kind of community health model that identifies individuals' risk based on some kind of health assessment or assessment, and then connects individuals to community-based resources, as Garth just mentioned, that addresses whatever that social or environmental risk need is. We go beyond that, and I'm sure the others do as well. We have, in addition to housing, because we touched on housing, I mentioned two other programs that we offer to support our Medicare Advantage members. One is called Navigate for Me. And Navigate for Me is, think of it as concierge service. Caraline was just talking for someone who has Alzheimer's. I have a mother who has dementia, who's in assisted living. So you're absolutely correct, Caroline. The services she needs are different than maybe a traditional Medicare Advantage member. So these navigators are able to really understand in a concierge kind of way the needs of that particular individual, not just a population of individuals, but that specific individual, and identify future health actions that would be appropriate for that individual so they can anticipate any care that should be there or care that's needed, and continuously screen for risk factors that could be present. Another one is our house calls program, where we're going once a year, and similar in theme to Navigate for Me, where we go on once a year to evaluate the individual, do a wellness check, and do that because we understand, based on health condition or some other social risk factor, that people are unable or unwilling to get to the care, so we take the care to them.
Thanks, Michael. So this is interesting. I know that Humana has a similar program. I'm glad actually that, Garth, you brought up the issue of isolation, behavioral health being a very critical component of systemic health. And Caraline, I believe you all have a similar program to Michael in terms of leveraging college students, correct? Who go into the homes of these older adults and help out in terms of that issue.
Yes, it's not our program. I think we all probably contract with PAPA.
Okay.
Based here in South Florida, but there are other companies like them as well, or similar concept, right? Where they, yes, contract with people, in this case, college kids. Now, with COVID, it kind of transitioned a little bit to virtual and telephonic, but just that in measuring, providing that social interaction. And so, Garth, we probably used the same indices where we looked at the UCLA index and measuring the pre and post and also healthy days. And I will say, I have not seen any intervention generate such significant results in that social isolation and loneliness index and healthy days as a program like that, where you provide, you have, we all could relate and have those stories, right? A woman, for example, was on her way to the emergency room and felt lightheaded, and her Papa Pal got her orange juice, and she just kind of calmed down. And so you don't need a big spreadsheet to figure out not only is there an ROI there, but it was the right thing for her.
Right.
And then trust develops with that person. And so I think it's a lot that we all recognize. Care doesn't happen in the physician's office, right? Care happens outside of those walls and in the home, right? And the more we can get our eyes and ears and trust into the home, and I think we've all probably experienced huge increases in telehealth and ways to leverage that. So some silver linings that will probably be with in our future for a while.
Yeah, no, thank you for that. So, Michael talked about identifying risk, connecting to resources. I'm real curious, we talked about COVID-19 earlier. And I'd be curious to understand how COVID-19 has heightened awareness of health inequities at your organizations. And has this awareness impacted the work that you're doing? Absolutely. And Gary, we haven't heard from you, so perhaps we could start with Gary.
So COVID-19 obviously has been an accelerator, but it also happened at a time when the country was looking at social justice. It was this weird juxtaposition of the pandemic and the issue of social justice coming together. And it put the spotlight on the healthcare system and the inequalities that have been there. It goes back to W.B. Du Bois, at the turn of the 20th century, not even the 21st century. So these COVID actually made us all stop and pause and understand. Again, though, what I'm excited about, and COVID obviously is part of the change that's evolving. But what I hear from the other panelists in the work that they're doing is business interest in people's health. I think that that's probably the most important thing that's going to happen to our country. When we, as a matter of business interest, are looking at our communities and trying to make them all healthy. that is an extraordinary thing because we become invested in our neighbor's health, because we are doing it as a matter of business. And I say that purposely because there's some that think there's something wrong with the business of healthcare, that somehow healthcare ought not to be a business. And I think they're actually wrong about that. I think, and this is one of the things that fascinates me so much about Medicare Advantage versus Medicare fee-for-service, because in Medicare Advantage, the business interest is trying to make sure that we're improving the quality of life, conserving life, doing it in measurable ways, intervening in advance where we hadn't done it in fee-for-service program. And COVID just accelerates all of that, right? Because what it's made visible is the inequalities that are measurable. And now you can see the companies making the investment, now understanding where the problem lies. I think that's transformative. I think we don't recognize it because we're so close on it, right? And we don't have that historical lens that tells us how different this is, but it is fundamentally different from anything that has gone before in American history. I can tell you that much.
I knew you would
Gary,
bring up that historical piece. Yes, go ahead, Carol.
I might steal that from you, Gary. Our CEO, Bruce Broussard's often quoted by saying he wants to transform Humana from an insurance company with elements of health to a health company with elements of insurance. It's kind of what you're saying, right? The business is caring about people's health. So start to hear that. I'll give you credit.
That's what the 21st century is about. That is the 21st century. That is 21st century healthcare. Very different from the 20th century. Very, very
Daniel,
yes,
just
Mike.
to layer in there and kind of pile on.
Yes.
We've been doing health equity work. I've been working at the organization and doing health equity work for 10 years. So this is not new to us. And health equity work was going on within the company before I started. When I came on board, hopefully I've helped to coordinate efforts and that kind of thing. But here's what I wanted to point out. Absolutely, this unfortunate circumstance and reality of this thing called COVID, but it's not just COVID. So it's really the imperfect storm. It's the imperfect storm of the death of George Floyd, COVID-19 and the disparities associated with COVID, and social and civil unrest. And then you sprinkle in all sorts of other things that are going on as well, the election and all sorts of things. But you put all that together, and that makes for, at least in our case, not a new focus on health equity, but a more urgent and immediate focus on health equity and health disparities. Everything that we're talking about doing here and that we're talking about within the walls of UnitedHealth Group, I can honestly and sincerely tell you, none of it is new discussion. As the health equity guy, what really jazzes me up is there is an increased urgency and immediacy around addressing it, not it being new.
Thank you. Garth, did you want to add anything?
I'm so slow to come off mute. But I'll say, one of the interesting things that Gary is alluding to is a lot of us work together. So, everyone on this panel are partners in a variety of different ways in terms of ways in which we have worked together and, tried to work together to make communities better overall. So there really is a very nuanced dynamic of how we, I think, have been collectively approaching the issue of community health, collectively tackling, social determinants of health, and collectively, I think, taking our country to a better place. And so to Michael's point, I think Caraline even touched on this earlier, and I think kind of underscoring Gary's point, I think there is a renaissance around leadership around these kinds of issues. Some of it, I'm going to exclude myself, I'd say some of it is exhibited by the leadership you see here on this panel. But it is a different time period where these conversations and the work that Michael, myself, Caraline, and others have been doing for a long time are becoming to the forefront. And you'd have heard about it in a variety of different contexts within the conference today. And you'll continue to hear more about it because I think healthcare is changing, and these are the kinds of things that are now on the forefront of people's minds, from my grandmother to folks who are clinically working on the front lines.
Yeah. I would just add to this that there are lots of other changes going on that are propelling this. I mean, America's becoming more diverse. The browning of America means that those who did not have access, I know, Daniel, when you were working on the Affordable Care Act, 48% of African Americans had no health care.
That's right.
Yep. And 54% of Hispanics had no health care. I mean, they had no insurance card at all. And so those things have fundamentally changed, and we've brought that population into the healthcare marketplace in a real way. Not rescue care, but now we're providing them with care that can preserve and help them live high quality lives. When I got involved in healthcare, Margaret Heckler's report in 1984, yeah, people were working on health disparities. Healthy People 2010, we were going to eliminate health disparities in 10 years. I mean, when I signed up, I thought, yeah, okay, that sounds like a great program. Let's get that done, right?
Yeah.
Healthcare. Booker T. Washington had National Negro Health Week. The federal government funded that through the 1940s and 50s, right? So yeah, we've had health disparities conversation, but this is fundamentally different. And what the different piece of it is that industry across the sector, healthcare sector, is looking at healthcare, I would add, in a competitive way as well, because that's what helps drive our economy, right? Is the competition of it. And what we're seeing is the investment of these plans, of hospitals, of physician practices, they're all coming together, I think, in a unique way. Certainly very different than I experienced and I know, Daniel, you've been on the front line a long time. This is a very different conversation.
Yeah, it is a different conversation. And Gary, I actually want to stay with you for a moment and pivot. We talked about the ACA. We talked about, that political determinant of health. I know Caraline raised it, something I'm very interested in terms of my research. So I want to ask you, as we are entering, or we have entered in many respects, this presidential election, right? How do you envision the presidential election results impacting efforts to address health inequities among Medicare populations?
So the first thing that we have to all acknowledge is that health policy is a branch of medicine, right?
Yep.
Because if you ain't advocating, you ain't getting. I mean, that's the nature of the beast. It is. That's true. It is a branch of medicine, and again, this unique confluence of the virus that's disproportionately impacting minorities, particularly African Americans, higher mortality rates and hospitalization rates and all those sorts of things, as well as the social justice conversation, means that it's coming to a head. And so the next president has to address these issues, right? And what you see right now is what I'm talking about. People are standing in long lines, and you hear them saying as if their life depended upon it, right? Because they have that feeling that their very lives depend on making sure that the health policy that comes out of this election, right, is concerned about them. And what we can anticipate from that is that everyone anticipates that healthcare is going to be on the agenda after this election, that we fundamentally have to reimagine the system that we're living in. And that reimagining, as you can hear from the conversation, has already begun. It needs to be supported. I'm one who fundamentally believes that we need to make deeper investments in Medicare Advantage. It is where we have to go for all of the reasons that you've heard in this conversation today, and more that I can give you. And so my expectation is, I don't want to be a prognosticator, but what I will say is that my expectation will be that we'll be on a very different trajectory after this election, because people understand that without a plan, we can have very, very bad outcomes, not just in health, but in our economy, in our lifestyle. And so I think there's a movement afoot here that I think will be apparent in about 21 days.
Yeah, thank you. Thank you for talking about that, Gary, and giving that perspective. You know, we know that the uninsurance rate has increased about 500,000 each year for the last 3 years, and we've seen Medicaid enrollment across the United States declining. So it does have a lot of implications for us in terms of elevating health equity in communities across the nation. So I want to pivot now to Garth for a moment. You know, since we're on this topic of health policy, not going to ask you a political question, but I do want to, you know, move towards one area of health policy that has received bipartisan support, both from Democrats, Republicans, Independents, you name it. And it's this issue of value-based care, right? This notion of increasing value for folks, improving the quality of care. And I remember back in 2012, you had authored a peer-reviewed journal article for Health Affairs, you along with other thought leaders in the health equity movement. And there was one article in there, while most of the articles were praising the health policies at that time in terms of elevating health equity, there was one that was sounding the alarm about value-based care and saying that, well, if we don't think very carefully about this, right, and strategically about it, and take an equity lens to this work, it's really going to exacerbate the inequities that we already see. And we know from AHRQ that based on their annual report on healthcare disparities and healthcare quality, that in many respects, the states that have achieved higher quality, better value are the states that have the highest disparities in healthcare. So the question for you, Garth, is, do you believe that a value-based care model can advance health equity as we're moving forward and it receives greater traction?
Oh, wow, Daniel, you took me back there. That was, you're right, an article we wrote about 8 years ago. And I think
yes,
like Michael, like Gary, like yourself, like Caraline, so many of us have been at this, you know, for you know, a decade or longer. And, you know, what we were writing about back then was the point that we need to incorporate health equity and social determinants, even though we weren't using the word that much back then, into the concept of value-based care and into how we considered and even define value and how we bring that full circle. Like Caraline, like Michael, I think we have embraced that concept more fully now, particularly in terms of how we are able to kind of incorporate social determinants and addressing social determinants of health into value-based care. And it's funny when you mention that article because, you know, 8 years ago, I think we certainly would have viewed that as certainly in the policy circles, that was viewed as more foreign back then. And I think we're trying to raise the alarm that that's what we should be doing now. And now I do see, to Gary's point of a new day, I do see leadership that has changed that. I see some of the work that we've done. I see some of the work that my colleagues here have done, where we have really worked to try to integrate and link value. Now, Gary was giving some nods to the past and to the future. So let me also give a nod to the future. That needs to grow and continue. The efforts that, whether it be coding efforts or other similar kinds of efforts, try to expand on that, that needs to grow and continue and evolve as the issue of value evolves. And the thing from 10 years ago to still relevant now is that people are still being challenged by the social environmental conditions. That hasn't changed. So I know what my communities, you know, places where I grew up, where I came from, people value the ability to be healthier, but just not free of clinical disease, but live their best life. And so addressing these social determinants is about doing that. So it's funny you mentioned that. I do remember, Dial, back then, and being just like, we got to make sure we do this, and a lot of folks are doing it now. And again, kudos not just to ourselves but the people on the panel as well, who I think have led similar efforts to make sure that we incorporate value into the issue, social determinants of health into the issue around value.
Yeah, no, I appreciate that. And I just want to give, the rest of the panelists an opportunity to chime in. What are your thoughts about that question, if you have any?
I'll chime in. I led our value-based strategies team for a few years, so it's near and dear to my heart. And frankly, it was part of the reason I had interest in moving more into population health, because I think there just needs to be a marriage there more than we've seen. I don't know that our industry has been as ready for it as it is now, so that's really exciting. But listening to you, Garth, just talk about it makes me realize I think we need to define what value means, right? And if you just look at the evolution of our, at least I'll speak on behalf of Humana, our value-based models, particularly in MA, have largely been around more of the clinical outcomes. Qualitatively and quantitatively, but HEDIS and stars and utilization and all of that, and it kind of our healthcare system, I mean, to Gary, your point, just historically, it's built around an acute episodic event, from payment to benefits to everything else. And so I think tackling the word value and what it means to providers, and I say that deliberately slow, not just clinicians, but also community-based organizations, and reimbursing CBOs on outcomes-based type results to kind of create some sustainability is long-term where I'd like to see us go. But I think it's fundamental to changing the way we reallocate the dollar within our healthcare delivery system to provide for more time spent with patients, to reimburse for things like unconscious bias training in our provider offices, clinical and not. And so long as we focus on just that fee for service kind of traditional, we'll always be fueling a very episodic acute system. And so I think the movement towards value has been where we've all been focused the last several years, but I challenge us, including my colleagues internally at Humana, to redefine value a little bit. We're starting to look at integrating social determinant of health components, whether it's referrals or connecting to resources or even coding into certain value-based models. And so we'll see what those results generate. But I would expect that marriage between value-based and population health, if you will, to be the next evolution of how we talk about value.
Then similar to what you've heard from Caraline and Garth, value-based care is going to be as effective as the data and inputs that we have to evaluate and assess it. So, data and clinical insights are core competencies of UnitedHealthcare. So being able to not just look at sort of a generalized outcome or series of measures or metrics, but being able to incorporate very intentionally and purposefully the right demographic data of those being served, so that we can stratify the results of their outcomes, looking at this from a health equity and value-based care lens, so that we can truly see if it's working for the good of all of those that we're trying to serve, not just a mosh pit of everyone aggregated into one outcome metric. So incorporating the right data is key. Value-based care could be very important. We'll have to assess it and evaluate it appropriately.
Love it, Michael. So I want to switch now, the few minutes that we have left, to talk about, harnessing that power of collaboration. We've talked about what each of your organizations have individually been doing to advance the cause of health equity in this country. And I want to switch over now to, can you provide us with examples of how your organizations have collaborated with other entities or even together, right, amongst yourselves to promote health equity? And Michael, I'll start with you.
So to promote health equity, so what I'm going to say, Daniel, is there are a number of things that we have done well, and have in the hopper to do now, and the plans and strategies to get things done. When I honestly and candidly look at where there are opportunities to do more and do better, it is exactly in the question you asked. And those opportunities lie in non-competitive collaboration with the partners that you see here, as well as partners that aren't represented on this panel, to do more collective good. For example, unconscious and implicit bias training. There really is no competitive advantage for, and just to use as example, UnitedHealthcare to develop a training or series of trainings, promote and encourage all providers to take it, and our providers, well, I don't even want to say our providers, the providers that we're promoting this to and encouraging to take it, take advantage of it, because guess what, Daniel? It's for the benefit of all the patients and members that we have, because if they're in the UnitedHealthcare panel and our online directly, they're likely in Humana's, they're likely in CVS, they're likely in the Blues, they're likely in Cigna. So in so much as we can work together to identify those opportunities, to do something that raises the overall health equity vote without taking away the competitive spirit that we all have for our companies to be the best, then I challenge myself and I challenge the rest of us on this panel. Let's get together and figure those out.
I love that charge. I love that challenge. Caraline, Garth, Gary, any comments?
Yeah, you're reminding me, it wasn't that long ago, we were hosting a summit, I think in San Antonio, Texas, and we were looking to get other plans to participate on a panel with us, similar to this, but it was in person. And I remember the conversation about, is that okay? I mean, we still kind of this competitiveness. And so I don't underestimate the power of this panel. And,
all right.
And the natural inclination for all of us to join. I think we're very hungry for the conversation. I'm actually leading a work group that includes leaders from both of your organizations and other plans to talk about the community-based organization network, to talk about moving toward a bigger network. And we've even joked, we said, we're not going to compete on who has the best food bank network. Like, that's not, we'll find ways to compete in technology and other things. Trust me, that's how we're all wired. But we're in active discussions, just as an example, Daniel, where payers are coming together with third parties, with objective voices to keep everything on the up and up, but to talk about how we can come together to do not the right thing for the plan, but to do the right thing for the people in the community.
And Daniel, let me just add a couple of things. I would say one, the colleagues you see on this panel are folks that we've all kind of collectively worked together and have colleagues within our organization work together. So I think there is not only opportunity, but activities they're happening. And I really, to Gary's earlier point, I am encouraged by just our spirit of not just collaboration, but how we all collectively care about communities. I think you've seen that repetitively said here. And so I would say that was one area that I want to segue and say that we should continue to collectively focus on is how do we support community-based organizations to do this work? How do we, work with folks on the front lines who are doing much of the kinds of things that we're alluding to here, but are executing them on the front lines as well. And that's where we have to kind of continue to collaborate in terms of how we work collectively to support those organizations in the community. But I will definitely say I consider all of the folks on the panel colleagues. And we've already, I think, connected in so many different ways. And Gary said it earlier on, I still continue to say that it's a different time. I think the commitment to community, the commitment to changing lives is there, and I think will continue to be seen.
Thanks, Garth. Go ahead.
Yeah.
Sorry.
So the National Minority Quality Forum, we are about collaboration because healthcare is a collaborative enterprise.
That's right.
I understand the marketplace, but at the end of the day, down in community, we are collaborating with each other to make sure that people have access to quality healthcare. I love this idea of finding in that pre-competitive space places where we can do things together. Part of it, and I would say that's important, is changing the culture of healthcare. There are people out there who still believe that their neighbors should not have health care. We have to say that out loud. There are people who they fundamentally believe that. And they have a right to do that, essentially. But we have to persuade them otherwise. We have to show them examples. And I think coming together, we can build that deep collaboration that really takes what is extraordinary capacity. These three companies here are leaders in the healthcare space. They can transform healthcare at any moment they decide to do it. And so the only thing I would encourage them is really the patient voice, to make sure that you really understand the patient voice by making sure as you build your collaboration, you've got the patient voice at the table. Because at the end of the day, that's the end user. That's who we're all working for, is that patient.
Yeah, thank you, Gary, for that comment. And Garth, I appreciate you talking about the collective forces and supporting community-based organizations. I think, at Morehouse School of Medicine, at the Satcher Leadership Institute, we believe that the people who are closest to the pain should be the ones leading the solutions, right? And I'm glad to hear that all of your organizations identify with that premise and have been working locally, right, with these organizations. Let me, in the few minutes that we have left, I was going to ask one final question, and then we'll go to final thoughts, and then I'll close out. And this question, I just want to start with Caraline. It's how can your organization empower vulnerable communities, right? Since we're on that premise of communities being the focus here, to move the health equity needle forward. How can your organization empower vulnerable communities to move the needle of health equity forward? And how do you measure success?
Yeah, well, Gary, I agree with Gary's comment earlier about just continued investment in Medicare Advantage plans. I read a statistic recently, so all these MA plans, I think that about at least 40% of our members live on an average income less than $20,000 a year. Those are vulnerable people.
Yes.
And so we can continue, if we continue to invest, all of us, in growing MA and enrollment and acquiring and retaining and helping to surround ourselves around those people and those communities to make sure they live their best life they can. There's a lot of power in that, right? There's a lot of, we can provide the resources. We do, because of COVID, we just are close to delivering our 1 millionth meal since March. I mean, just things that, and I'm sure other organizations have done things like that too, delivering masks and care kits and things to help, being able to use the data that we have to go upstream and identify who is most vulnerable, who is most in need, and then not just having a blanket of solutions that are, agnostic to all, but being a little more tailored and specific to the most vulnerable people and communities. And I think the plans here are well positioned to continue to do that. So it's a simple answer for a complex question, but I think really just continued investment in that and retaining our members, understanding their needs, surrounding ourselves around their whole person health, and understanding that we, by default, are acquiring a lot of the most vulnerable people out there. And I think we can be even more resourceful and available to the populations, especially look at the baby boomers coming up and everything, right? I think we have some resources that can help invest in their total healthcare needs to break down some of those inequities. And then tons of other things, right? I mean, getting aligned, like you said, Michael, on unconscious bias training, right? We don't need to come up with our own. Let's work together. Let's leverage that and deploy that and be really loud and bold that this is what we expect of all of our providers and everyone who interacts with our people.
That's right. Well, thank you, Caraline. We have about 2 minutes left. I wanted to give each of you about 30 seconds to give us some final thoughts. And Michael, yes, why don't we start with you?
Sure, I'll jump in very quickly. So very simply put, 3 things. 1, be even better at integrating and incorporating the right data, the fullest suite of data about those that we serve, so that we can better identify where disparities and gaps exist. That's number 1. Number 2, use that information to, as Caraline said, tailor our programs and services to best address the unique and specific needs of individuals, because sometimes they're going to be the same, many times they're going to be different. And third is what we talked about a little while ago. Really look for those opportunities where key partners and stakeholders can be brought together to do things for the collective good that really address the needs of the overall healthcare system, and not just focused on the population of individuals that we all have the privilege of serving, really impacting the healthcare system as a whole.
Very good. Garth?
Yeah, so I'm going to take both. I know from what Caraline said and what Michael said. I think Caroline's right in terms of our onus of responsibility addressing the most vulnerable of communities, many of them who are right in front of us on a day-to-day basis. I think Michael's point about data is key. We saw that earlier in COVID where, being able to define the impact on Black and brown communities was not as apparent as it should have been or as fast as it should have been because of challenges around data. And I would just probably close by reemphasizing the earlier points around understanding what's happening with the community-based organizations, all the components of what the most vulnerable kinds of individuals interact with, and how we create that ring of support through our various programs. Research Living is what we have on our end. You've heard Michael and Caraline describe the things that they're doing on their end. It's all about how we support those programs. And to Caroline's earlier point, we have to evolve how we continue to do that appropriately to meet the need. And that's what post-COVID United States is going to look like. A lot of need initially, but hopefully a lot of upliftment afterwards.
Thank you, Garth. How about Gary?
So I would just remind everyone that your companies are also employers. Healthcare is the largest employer sector in the American economy. It's bigger than manufacturing. You can help these communities by leveraging some of your abilities to hire and put people to work. Sometimes that's all these communities need is some opportunity. If you look at the minority community, some of the highest unemployment, particularly coming out of COVID. So besides delivering the care, you can use people in the community to deliver care and make that investment. It would be extraordinary.
Great point. Caraline?
Just quickly, I echo everyone here, and to Gary's point, looking internally at our own organizations and our own associates, and just I challenge all of us, including myself, to listen more, right? Listen to our employees, listen to our providers, our members, and our communities.
Well, thank you again to each of our distinguished panelists for the privilege of your time. We thank all of you viewing this session for joining us today as well. And I hope that you've gained some new insights on the challenges of health inequities, how we can work to address these challenges and realize health equity for all moving forward. Very exciting collaborations involved to help inform and advance this work. I hope that you'll get involved. Thanks again to all of you for joining us. Have a great day.